Today, I'd like to take you through consent for surgical procedures as undertaken in the surgical unit. This will be a two-part lecture series, and it's designated for students in Year 6 of the MBCHB program at Maseno University. The objectives of the lecture will be, 1, to define what surgical consent is, outline the importance of surgical patient consent, define the ability of a client or a patient to offer consent, discuss 3 aspects of surgical consent, define what informed consent is, and then briefly define the principle of surrogate caregiver and next of kin. As a preamble, we need to be cognizant of the changing aspects and of the practice of medicine in the world. From the time when the doctor was the know all, give all, and his instructions were final, to currently where you are pushed as a clinician to get more and more information to ensure that your patient, 1, is more informed, that you are also giving the adequate information, and that you are both at par. The definition of informed consent. Informed consent is defined as permission granted by a patient to his or her clinician to carry out a procedure or intervention in the full knowledge of the proposed management plan or intervention, with the knowledge of the anticipated outcomes and the possible consequences, as well as risks and benefits. Currently, this is preferably written, but even when it's not written, it's advisable that it's always documented. Why is consent so important? This is for 4 reasons. 1, consent ensures that the patient is educated. Consent that the patient, even as he or she is making a decision to have or to decline an intervention, that he is well aware of all the aspects that we're going to discuss of the intervention. It also safeguards the rights of the patient from being overruled by the team that is managing him. We'll also get to learn a little bit about that one. It prevents any misunderstanding where the perceptions of the outcomes by the patient and those of the clinicians or the provider are different, and the outcome then becomes unsatisfactory to either party. And lastly, it's a medico-legal document that you can always revert to should there be dispute arising from the intervention of the procedure. Why do we emphasize that the consent has to be informed? 1, every patient is different. Every patient's understanding of the procedure is different. Every patient's physiology and pathology that brings them to have this intervention done are also different. So the consent is taken with all this in mind and in view of the individuality of the patient. Secondly, even as the provider might have specific outcomes in mind, the patient might have differing outcomes. So each patient may want varying outcomes. And I would like to give an example at this point, like if you have to do partial lobectomy or breast conserving mastectomy for a patient who has breast adenocarcinoma, whereas some patients would willingly settle for a modified radical mastectomy, other patients would want slightly different outcomes. Others would wish to have as much of the breast tissue preserved. Others would want other cosmetics, may have other cosmetic aspects in mind. So each patient you have to discuss so that the outcome that is planned is desirable both to the patient and to the provider, healthcare provider. Thirdly, each patient is autonomous. Being autonomous, they must have the right to integrate the information and make a decision as a person, not as a textbook stage of the pathology, not as the practice of the clinician or the surgeon. Yeah? And to make all these three aspects, all the decisions of the preceding 3 points, the patient needs information to follow up this. He needs the information given in forehand, given comprehensively, concisely, so that they can make an informed consent. There are 3 parts of what we call informed consent. There's disclosure, there's patient information, and there's decision making. At disclosure, what we ask is that you need to be brief, concise, and as clear as possible as you're disclosing the nature of the pathology, the nature of the intervention, the indications, the risk, and possible outcomes. The more you do sometimes, the more you try to elaborate and go deeper, you may find yourself as a clinician veering off from the close bigger picture, or you may find that you go into territory that goes on to hasten any anxiety from the patient. This is not to say that you hide information. Yeah, it must be concise so that every aspect of the disclosure is attended to. So when you're disclosing, you must discuss the diagnosis. You must include possible causes for the diagnosis. Please note the emphasis on possible, because there are variant pathophysiology to the same diagnosis. So what you could do to the patient is outline possible causes, but you cannot definitely tell them that this is the case unless if you have trauma or if you had a preceding pathology that may have led to that. Times when you could give possible causes are, for example, a patient who comes with ulcer on the leg that is suspicious for a Majoline's ulcer and has history of burns on the same surface 20 years ago. Then you can directly correlate that. But if we revert back to the patient, the example I gave earlier of a patient who has breast carcinoma, you might not be in a position to tell them what caused the breast carcinoma, but you could outline for them causes that are inherent in them or not known in them that would have caused it. Explain the indications for the procedure. Yeah? Explain why you want the procedure done. When you're indicating doing the indications for the procedure, you must also bear in mind the progression of the disease. You must give them the natural progression of the disease should the intervention not be taken place. You must, fourthly, you must give them potential benefits of the procedure. Why is it that you as a team, or you as a primary surgeon, or you as part of the team that is proposing the surgery are proposing it, or the particular intervention? This one has come out clearly from the healthcare provider. While you're giving the benefits, you must give out the potential risks of the procedure. Okay? And when you're giving potential risks, sometimes the patients will ask you, what are these percentage of this, what is the percentage of that? We will tackle that one later when we're going to discuss a little bit more in the practice. Please focus on the values and the interests of both the patient and the clinician. Like first, those of the patient. Okay? If the patient tells you that this is what I hold value, this is what is valuable to me, or I would wish to have this and the other one, that comes first. But do not forget the values and the interests of the clinician as well. So if a patient comes in and requests for an intervention that goes against the values and interests of the clinician, then you have the right at the disclosure phase to come out and say these are the moral values, or these are the ethical values, or these are the clinical values that we have. Yeah, you could also tell them that my interest as a surgeon is more in this field, so sorry, for now I might not be the one who will proceed to give you this, but I can give you a referral to a colleague who can do it. Then please discuss available alternatives. When you're discussing available alternatives, this may be guided by several things. One, it may be guided by your skill level as a practitioner, okay? And you must disclose this, and you must say that at my level, this is what I can do. So because I feel, or I know that I am not competent enough to handle this procedure, allow me to ask someone else to do it. Okay, you could also ask and say, okay, I'm going to do this procedure for you, but I'm requesting for the presence of a senior colleague, or I'm requesting for the presence of a peer during the consultation. When you're discussing the level of alternatives based on the levels and the capacity, you also must discuss the institutional capacity. So if the procedure or intervention is available in another institution, but your institution does not have the capacity, you must offer the patient that as well. So that if you're discussing and your offer coming to, and you settle on a procedure which for that time frame or that setting is inferior, and there is another alternative 20 kilometers away, 100 kilometers away, you must advise the patient, yeah, that yes, we're going to do here, you have holylithiasis, you require cholecystectomy, but the best practice for cholecystectomy now in patients with lithiasis is laparoscopic cholecystectomy. So I would advise you that yes, we can do open here, but this is the morbidity associated with this procedure. There's a there is potential for you to have laparoscopic cholecystectomy done at this level of the procedure. Where there are options for non-surgical management of the procedure, this alternative must be discussed with the patient. Yeah? And when you're discussing the non-surgical management, if either the surgical or the non-surgical has certain pros and cons, this must also be brought out and shared with the patient at that level. Okay? At times, there are conditions where there is option to discuss lack of not to intervene, where no intervention is an option that needs to be discussed. Please share this with the patient. I would like to give an example. You have a patient with a malignancy at a certain stage. If they undergo surgery and subsequent chemotherapy, their 5-year survival will be this, the morbidity associated will be this. Okay? But if they have an option of not having any intervention done, then the 5-year survival will be this, the morbidity will be this. This must be discussed. And when you're discussing alternatives, always remember to share data. Always remember to share data. Yeah? And when you're sharing data, as much as possible, be brief, be concise. Do you have to share percentages? You don't always have to give all the percentages, but you can give approximate percentages. So instead of telling a patient 73.5%, there is no harm in telling the patient 73% or telling the patient more than 70%, so that it depends a lot again on the understanding of the patient, but the patient needs to have a feel of what this is. There will be times when you, as a healthcare provider, will be asked by the patient, yeah, to help them make a decision. They'll come and tell you, yes, Dr. You've told me this, you've told me the other one, but what would you advise? Yeah, please, as much as possible, when it comes to that, do not let it be your decision. You allow them time to consult. Okay, so you give them, you disclose the information, then you allow them time to consult. Sometimes when the patient has settled on experience, you would still want to know, yeah, what is your experience as a person with this? What are your outcomes? Yeah. If you are better with one procedure than in the other procedure, and the procedure you're better with is not the gold standard for that particular pathology, you must, at that point, yeah, come out and say that as much as I'm good in Bassani's repair, the gold standard for inguinal hernia repair currently, yeah, is hernioplasty with mesh hernia repair. Okay? That one should also be shared with the patient. Once you've disclosed this, you as a clinician have the obligation to gauge or assess the patient's understanding. Yeah? And you must gauge the patient's understanding by one, gauging the responses that they give. Is this a patient who is constantly agreeing with you and not asking any question? Okay. So is this a patient who has come in and said, the doctor will decide for me? Is this a patient who is asking probing questions? Is this a patient who needs more clarification? Yeah. So if the patient is asking probing questions, answer them to the best of your capacity. Where you need further reference, you would ask the patient to allow you to do a reference. Where you have material that you can share with the patient, share with the patient, show them the material so that they can also go out. Yeah. Allow the patient to get clarification from other sources. Allow the patient to get the clarification from you as well. Yeah. So if a patient comes and asks you, yes, Dr. You've told me this, but please clarify this or the other one for me. Please clarify for me the length of stay. Please clarify for me how long it will take me to get back to work. You would be obliged to offer that one. Rarely, I repeat, do you give your preference. Rarely. What we need you is to share what you have. Yeah. Share your skill level, share the institutional norms and capacity, then allow the patient to make. Should you make a statement that you are not comfortable with, you are allowed at this level to recant and tell the patient, I did say this, but I now feel that maybe that should not be what I should be offering. You are allowed at that point. Okay. Once you've given the patient the information, yeah, and you've assessed how they've done it, then please allow the patient time to consult. The decision making usually involves many more factors. Please be wary of the patient who walks into a consultation room and says, I want surgery. I want surgery. You should always ask him. If it is elective, please ask them. This visit was to discuss for disclosure and information sharing. Please come in 1 week from now. Yeah, please come in 2 weeks from now, then we can have time to consult. There are times when the patient will ask that you allow another member of the family to come in. Please oblige, irrespective of the age of the patient. It doesn't matter whether he's 45 and he says he wants his 18-year-old daughter to come in. It doesn't matter whether she's 70 and she wants a granddaughter who's 16. Please allow the family to ask questions as well if the patient has allowed them to be part of the decision making. Okay. In scenarios where the patient or the family requests for a second opinion, yeah, you should not take offense that they are seeking a second opinion from what you have told them. Allow them the time to go seek a second opinion. They may even ask you, where do you think we can seek a second opinion? You should, as much as possible, not guide them to a specific person. Allow them and offer them several. So you could tell them that we are in Kisumu, there's this hospital here, which also has a surgeon. There's this other hospital there, which also has a surgeon. There's this other option, which has a surgeon. You could go to any of them and seek opinion. Okay? That is allowed. Once you have gone through the three aspects of the consent process, the most important one is the documentation of the consent. Okay? Before documentation, previously there was a trend to offer the patient the consent form and ask them to sign. And sometimes you would let them sign a blank form with nothing filled. Please, that is not allowed. Okay. So what you need to do is to take the patient through the documentation. And through the documentation, you detail all the possibilities, details all the adverse effects. Where there's anesthesia involved, okay, the form of anesthesia should also be detailed. Okay. Document the variability of the outcomes. If you're going to have any transfusions or infusions, please share with them. If you're going to have intrusions, intrusions means in terms of intruding on the patient's privacy, intruding on the patient's private space. So if you're going to have a patient under some form of regional anesthesia and he or she is going to be placed in lithotomy and you're working in the perineum, and there are going to be 4 or 5 people in the room, please, prior to the procedure, advise them on that. Okay, get their consent because they might just say, I don't want to be in lithotomy under spinal anesthesia. I would wish to have it under general anesthesia so that I sleep and I don't see anything that is happening or whoever is coming in. Okay, if you are going to take photos during the procedure. Okay, please seek consent for the procedure, for these photos. If you're going to do any recordings, please seek. And this one is also for everyone else in the operating theater. And then allow the patient to sign after the documentation. You may even leave the consent form or document with the patient and request the patient, to read it, go through it. I'm coming back in 10 minutes, I'm coming back in 15 minutes. And then at that point, you have it, you have the patient to sign. Always be present at the signing of the document. Always be present at the signing of the documentation. Okay. Then have the document witnessed by somebody in your presence as well. Please, documenting the patient's consent it is only after it is documented that this becomes a legally effective consent form that can be used and is counted as consent obtained for surgery.